And I'll go through and do a few housekeeping items while we get started. I do want to let you know we'll probably go about 45 minutes or so this afternoon. We're going to do the presentation, of course, with our guest speaker, Ed Ricks from Beaufort Memorial Hospital. We're also going to do a short technical demonstration at the end of the presentation, and we certainly want to open up time for questions as well. You'll also get a copy of the PowerPoint here by end of day or sometime tomorrow as well with some additional follow-up information. So again, welcome this afternoon to the Summit Healthcare sponsored webcast. My name is Tara Markey. I'm the Director of Marketing here at Summit Healthcare, and I'll be just kind of introducing the presentation this morning, or afternoon rather, for those folks on the East Coast, and introducing our presenters here in a moment. From an agenda standpoint, we'll be going through a general profile of Beaufort Memorial, and Ed Ricks is going to be discussing their general Meditech 6.0 migration path, going through some of his experience with that project, and then looking at integration and their interoperability landscape and some of their ongoing initiatives there that at the organization, things that they have completed and then things that are in the future. So we'll touch upon general physician office integration, some of their integration with their MedHost ED environment, their future interoperability plans as well, and as mentioned, open it up for Q&A. So again, today's presenter is Ed Ricks, Chief Information Officer at Beaufort Memorial Hospital. I also have joining us is Matt Johnson, our Product Manager of our integration platform here at Summit Healthcare. So with that, I again want to thank Ed for taking the time to bring this really important message to the Meditech community. And Ed, I'm going to go ahead and turn the audio piece over to you, but I will advance the slides as we discussed.
All right, great. Thanks, Tara. Good afternoon, everybody. First of all, just let me briefly tell you a little bit about Beaufort Memorial, just so that you can kind of put us in context with your organization. But we are a private, independent, not-for-profit community hospital, one of the rare breeds, still trying to stay that way. About 200 beds. We're on the southeast coast of South Carolina, so right on the Intracoastal Waterway. And you can see in the picture there, we're literally right on the water. We got about 11,000 discharges every year and just over 40,000 ED visits annually, and about 140+ thousand outpatient visits a year through our different modalities. Rapid community growth, and a lot of things in this area. It's a great retirement community, and even with the decline in the economy, we're still kind of growing year over year from our population and the patients that we serve. And we've done a lot of really cool things with technology over the years, and I think for all the right reasons, but I've been a most wired hospital for the last 9 years in a row. But the last couple of years have been pretty big for us, so we went through the process of migrating from Magic to 6.0, and I'll talk to that in just a moment. And then we were able to, because of doing that and getting that out of the way, test for meaningful use last year also. So some of the things that we considered, and this isn't just a migration seminar, this is really the integration component of it that I want to talk about, but the integration was such a key component of what we did. I'd like to tell you the story of why we did the migration from Magic to 6.0. And so when we looked at everything about 3 years ago here, having the Magic platform, knowing that we wanted to have this commitment to quality and patient safety, and like all hospitals, and had been using technology but still on kind of an outdated platform, we had a lot of strengths. So we knew that we wanted to move forward and progress, and particularly CPOE. Had a lot of support from our senior team, our medical staff and board to kind of make those efforts if we had the right platform, and had just a really strong IT team, which is great. So even though we're a relatively small hospital, I think we've got 23 people in IT, just a really good group of people. And so some of the things that really were driving us to move forward were the fact that we, even though I feel like we've done a lot of things well in the past year, very much a silo environment for some of our applications, and those within Meditech and even some of those that were not Meditech, and we just didn't have a strong technology blueprint moving forward, from the end user workstations to the infrastructure of what we had to how that all tied together to software applications, and I just didn't feel like we were really getting full value of some of the things that we had. So I hate doing that, getting an application or getting a tool and then only using a component of it because you either didn't market it well enough or don't know what you have. And then you folks who are Magic or have left Magic, you sort of know it. That's an outdated platform, very functional, runs like a tank. It's just hard to convince clinicians, particularly physicians, to change their workflow, to use a system that looks like it's 30 years old. And so our physician adoption had been relatively low, even though we've been successful in nursing and all the other clinical areas that we branched out into. It was difficult to get the physicians to adopt using the Meditech platform for us. So we knew that we wanted to change, but we knew that there were kind of a lot of challenges in front of us for that. Some of the things that we were dealing with is that our first effort here at CPOE, I think for all the right reasons and doing all the right things, had kind of failed miserably. A couple of years before I got an EDM module in the emergency department on the Magic platform, and I think everyone worked diligently and hard and tried to do all the right things and just couldn't get physician adoption. So while we were using it for the patient tracker and kind of the flow system and the nursing documentation, it was not being used the way we intended with CPOE and physician documentation online. And we just didn't want to repeat that effort again. I don't think we were going to get a second or third chance if we didn't get it right the next time. One of the things is that kind of the current integration landscape that we had was becoming very cost prohibitive, particularly when we were looking at going to the 6.0 platform. So we had to consider that as we moved on. And even though you're primarily a Meditech hospital, or we were, we still have other vendors in place, and there are other technologies and kind of wraparound tools that you need to look at. And I want to make sure that we had the right pieces in place that kind of fit into one long-term plan, like I talked about, and that they were complementary pieces and didn't kind of take away from each other. And so one of the big challenges that we talked about, probably the biggest thing that we talked about organizationally, and this is from the board down to every employee, was this was not going to be an effort of just taking what we had in Magic, making it work in 6.0. It was a process redesign, and I hate using some of those terms, but there's really no other way to define it. We wanted to look at the Meditech system, use it to its fullest potential the way it was designed to be used, not just force our old processes into a new system. That's a hard thing to do, far more cultural than it is technological. And we had plenty of good people, both in the IT department and throughout the organization, engaged in the whole process. It's a huge monumental effort to think about changing your workflow to improve the workflow, not changing it to fit a system. And it's hard to do. We're still working on that, and we've been live for some time now, but that was a key component for us. You really need, if you're going to 6.0, you really need a rock-solid infrastructure. Magic platform just runs because of the way they've built it. One of the best things about Meditech, but when you go to a true Windows client-server environment and that need for really good dynamic workstations at the desktop or virtualized stations, however you manage that, it's a key thing to have that in place before you make the migration. And particularly back when we made the decision, so I'm thinking backwards, I believe we signed our contract for 6.0 in June of 2009, so just about 3 years ago now. It was still a somewhat very immature product. There were only 4 or 5 sites that were live at that point in time. They were great reference sites because they were really willing to share what they learned and help Meditech make it better and helped us learn as we went along. But really an immature product. I think we've sort of progressed beyond that point now, but that was definitely a challenge of ours. One of the things, I just didn't want to spend the money, nor did I think we had the need for a lot of outside consulting in our migration. And I've said before, my theory on some of these consultants is I don't have a big use for them until such day I become one, and then all of a sudden I like them better. But we chose to not budget for a lot, although we did target a couple of key things that just were not going to have the expertise in-house or the available bandwidth to do. So, and I'll talk about that more in just a moment, but something to consider and move forward with. Okay, Tara. So how do we define what we're going to do to overcome those challenges and make sure that we were going to be successful? And a few of the things that really popped up to all of us organizationally were that we really needed some physician champions, and more than just the PAC committees that everybody's had for years, or some kind of advisory council or something like that that was voluntary. We needed to pay some physicians to actually work with us and help engage other clinicians in this process and help us define some of these workflow changes and things that we do. And so we hired a CMIO to help us with us. Since then, I wish I'd have learned this lesson sooner, we've actually hired, and I use that term very loosely. So we've actually contractually paid other independent providers in the area to help us from time to time when it's things that are relative to their specialty or help us iron out some new workflows. And really, that's helped with our engagement on the doctors. And then because we'd had that failed effort with EDM, and not everybody's in that same position, but we definitely were, and there was a lot of history that we had to deal with. We actually, even though we made the choice to move forward with Meditech 6.0, we chose to go with a third-party ED system. There's good and bad to that, but you know the good outweighed the bad for us, and so we made a choice to do that. But that was going to be not only something we defined that we had to do, but one of the challenges that we had to keep in mind as we move forward, because it definitely makes a much broader need for great integration in how we do that going forward, because the ED is such a central point for every patient coming in through our front door, essentially. And then, as I mentioned, finding the right technology partners, and this is key around integration, so that's definitely what I'm talking about, but looking at all the options and what you have to work with in our industry anyhow, and where the right fit is for us. I mentioned deciding to budget for certain consulting. We didn't do a lot of that, but we did pick and choose a few places that were very strategic for us. And not understanding maybe up front where all the gotchas are, what some of the real costs are when you interface, and it's more than just the first blush of here's the quote to convert all of your integration effort that you had in the past to the 6.0 environment. And we, from a project perspective, the communications marketing that we did internally to our organization was probably one of the biggest efforts that we had. And I think that probably one of the reasons we were as successful as we were, not that there weren't a lot of bumps along the way, but really trying to engage the organization. Every single employee of the hospital, every single physician who walked through here knew what was going on for months and months, knew why we were doing it, to some degree understood what the involvement of their particular job was going to be and how it was going to impact them. And then one of the things that I mentioned is learning from the earlier doctors. You know, if you're going through this process, and for those of you who already have, I'm sure you know that Meditech, one of the best things about the Meditech community is that it seems like the hospitals are very happy to work with each other and talk about their experiences, and I really like that. So we talked to the 4 hospitals that were live at that time a lot, still do, and we continue to talk to new hospitals that are looking at going to the 6.0, and we learn from them every time, and hopefully they learn a little something from us. And I guess probably the key thing, and particularly when it comes to the integration, but for everything, is keeping our long-term strategies in mind. You know, as we were doing the implementation, what are we trying to achieve, not just before the go live, but the next 2 or 3 or 4 years, and how are we making sure that we've got the building blocks in place to make that happen? And for us, by this point in time, it was meaningful use. That didn't exist when we made the first choice to go with Meditech, and so we sort of were lucky in our timing with that. But also, our state was starting a HIE that we wanted to be sure that we could work with, and even more importantly, is just integrating more tightly with our community physician offices. So the integration challenge, and that's really what this is mostly about. You know, you've got a lot of stuff going on in the organization with interfacing, and even though we're Meditech, we still had a number of other applications, some where Meditech just doesn't have a component, you know, whether it's PACS or something like that. We did something in our anesthesiology. You know, there just isn't a Meditech component for that yet. And in some cases, Meditech does have it. We just, for whatever reasons, whether they were good or bad, chose a third-party system. In some cases, we chose to keep it. In some cases, we're actually choosing to go away from those because it's making more sense for us now. But we still had to be sure that we could talk to all those systems at one time. And the physician offices, as I mentioned, you know, we had a lot of different third-party vendors that we had to talk to, both in the practices that we owned and, more importantly, on the other community practices. So planning for the migration, you know, our old environment from an interfacing perspective was really more of a scripted point-to-point interfaces. It wasn't what I call kind of an enterprise solution. And so while it had been effective, and actually we had a great degree of success, I think, with this other vendor for years and a good relationship, it just wasn't really efficient, and certainly didn't take advantage of some of the technologies that are available today, I think, to move us forward, you know, as we were looking at what we were going to do. And then the other thing to, I would say, consider is in your Meditech environment, if you've got a lot of custom interfaces, are you going to maintain those, go into the new environment? Is it possible to do that? I think it's something to consider. one of the things that you have an opportunity for in 6.0 is that you can actually go to a higher version of HL7 feeds. Gives you a little bit more flexibility, a few more pieces of data that you can use. You want to make sure that you have the opportunity to take advantage of that, I guess, as you move forward. And then, you know, I didn't want to risk point-to-point or third-party interfaces that weren't pure Meditech feeds as far as the ability to work well within the new Meditech 6.0 environment. And while Meditech says a lot of things about how proprietary they are, they still need to support HL7, and they do. But I didn't want to risk some really weird third-party things going on. So I wanted to make sure that we had true Meditech feeds that we were operating from, not something else. And of course, a big consideration for us was cost and what we were paying in the old world and what we were going to have to pay in the new world and what that was going to mean to us moving forward. So this is sort of a picture of our before integration, before our migration from Magic to 6.0, and this was in our old world. And while it looks like a nice clean drawing, it really is much more convoluted than it needed to be. And if you sort of look at the bottom, we say, here's Meditech, that green box down there. The things talking to it, either going out of Meditech, going into Meditech. We had a third-party router that actually worked with scripts, third-party scripts that were sort of the go-betweens for a lot of things. So those scripts ran back and forth between the router. And then that's what talked to most of our applications. And that environment worked. It was just cumbersome. And in fact, my particular staff didn't really maintain that. We just had the relationship with the vendor. We didn't have one central management. And so, like I say, while that picture looks fairly clean because it's well drawn out so that we knew what we were dealing with, it was a very convoluted process and difficult for us to understand and maintain from one perspective and afford to pay for from another. And in a few slides, I'll show you our accurate picture and what we ended up with. So the integration plan, we started looking at what the potential vendors were, and we had, as you all would, 3 or 4 or 5 reasonably good choices to think about moving forward, and particularly in the Meditech world, and vendors that have either some sort of integration engine, some experience possibly with Meditech. And so we started looking and evaluating those vendors, and certainly we had an incumbent vendor that we wanted to talk with very closely because we had a good relationship with them. But we wanted to make sure that we allowed enough time to really plan this, make the right selection, and get things in place before we were at a push with our go live on that. Some of the things that we consider, and I'm sure you folks all do the same thing, but do the vendors have experience, particularly in the 6.0 world? Have they done these migrations from Magic to 6.0? And when we were doing this, again, it was fairly early, so that limited the field to some degree for us. And then I would say, how much experience does one of these vendors have in that? Because it's, I won't say it's rocket science, but it's complicated, and you do want to make sure that everything's going to go smoothly on that go live. So getting the experienced vendor is one thing. Also, since we'd already made the decision, and by that point in time, it actually gone live with our new ED system, wanted to make sure that we were working with someone who understood that system and the full capabilities of it and could get the data back and forth. In fact, I think I've got a slide later on that I'll briefly go over. This shorter shows some of the details behind that one piece of integration, because while I say it's integrating to one thing, it's many levels and different data elements go back and forth in different HL7 feeds. So somewhat sophisticated, but very, very necessary to do that level of integration. I think for us to be successful, having a third-party application to make it as seamless as possible to everyone else in the organization. And still, while I hate doing this, sometimes you have to do it. You need scripting. Meditech used to have a stance in 6.0 that you can't script to it, and that's, of course, silly. We all know that that's not true. So you want to make sure you've got some tool sets to help you do that. There are definitely some non-HL7 pieces of data that you want to move back and forth or population references. And then the scalability, I think, is key. When we were looking at that first picture, if you really broke it down, while it looked like maybe 25 different things we were talking to, they really broke down to nearly 150 individual discrete interfaces that were running in one fashion or another. And I know that's only going to grow going forward. In fact, for us, it's grown since that point in time. So the ability to scale that as needed and not incur a lot more cost in the future was, I think, a key component for us. And so as we looked at sort of the total cost for doing this integration, it was more than just the one-time fee. There's probably a software component with each vendor, some sort of development services, what's the ongoing maintenance going to look like, and that's the stuff that just eats you up on the go-forward basis. And then the ability to use pure Meditech HL7 feeds, both coming in and going out of Meditech, I think were critical for us. And had they done it before? You know, had they worked with these other vendors? Had they worked with Meditech 6.0 particularly, I think was important for us. So we considered all those things before we made our choice to go forward. And I think another key thing for us that we learned along the way and sort of got this in place at the 11th hour almost, what I would recommend is if you make this decision, because it's a big process and a big decision, it's really easier to get this in place before you're just going live with Meditech 6.0. Get it running in the magic world. Redirect all the magic interfaces to be clean Meditech feeds through an engine, and then it's a little bit easier to convert to 6.0. So I'm sure there's no drama here that you all already figured out that we chose Summit for our partner in this process. And as I mentioned, you know, we had at that point in time nearly 150 interfaces. I couldn't believe the number when we finally. It took us probably a month of working with our old vendor to try to go through everything that we had to even come up with the number of true interfaces that we had. And maybe that's just bad management on my part, I'm not sure, but it just became an animal that was out of our control, I guess. And so it's nice to actually get our arms around it and be somewhat in control of the process again. But ironically, even though we sort of made the decision to go to a whole different generation of software, is what I call it, it's really a new platform that's far more enhanced than what we had, we actually were saving money over the old environment. I found that phenomenal. One of the few things in our migration where I can say that, which is great. So, you know, we buy the engine, and on an ongoing basis, you pay the support fee for the licensing for that engine. You don't have 150 point-to-point interfaces that you're paying support fees for anymore. Now, I did have to purchase some new feeds from Meditech. So I wanted a clean feed. If Meditech offered it, essentially we bought it. So, you know, whether it's an ADT feed out, but you buy it just one time, orders maybe coming into Meditech, results going out of Meditech, whatever it is. I think we're up to about maybe in the neighborhood of 13 or 14 Meditech pure feeds now, both inbound and outbound. And but we reuse those the multiple times, and that's the number that adds up to over 150 now. So, you know, there is a maintenance to Meditech for each of those annually, but now I'm paying the maintenance on 12 or 14 feeds and not 150. And it's huge. For day one, we were saving about $75,000 a year over the year before, and more than that over what the alternatives were with some of the other vendors that we talked to for this migration. The one I mentioned a couple of times, you know, on the consulting, that we didn't really use a lot of consulting services, certainly not in our nursing build or working with CPOE and all the oversights and all that. But we just didn't have the expertise, so I did bring Summit in for their interface migration services, you know, just have a dedicated engineer from their perspective that was essentially on our team for that next 6 or 8 months to kind of manage us through that process of working with the third parties, getting everything organized, making sure that we were testing appropriately, timely enough. I don't know that we ever do test enough or timely enough or appropriately enough, but you know, really putting effort in on that I think was critical for us, and probably one of the key things that we did, you know, and for not that much money, I didn't have the expertise in-house. Even though our people worked very closely on that process, it just eliminated one of the things where we were the final factor on making sure things got done. Too much effort on too many other things, so it was the only way we were going to make it. A lot of third parties to work through, and a lot of time to do a lot of that stuff, and many cases, we never even had a true test environment for some of those third parties. So, you know, just building that took time, took effort, took coordination, maybe I should say. And so we did do the outsourced migration services with Summit for that component, and have actually chosen to stay in that mode with them since then, although it's a more limited capacity. We still do for everything that we're working on today, and as we're planning for the future, we just keep a Summit engineer sort of on our team. And so, again, I'm paying for a fraction of a full engineer, but yeah, we've got someone who's an expert in this engine available whenever we need it, and has worked with most of these other vendors, and it's just worked out really well for us to kind of continue in that mode. Next slide, I think. So I mentioned our ED system, and, and I'm not trying to sell one system over another, but for a number of reasons we chose this system in our emergency department. But just to show you the level of complexity, it's not, you say you interface to it, and you have to do that to make it seamless for the other clinicians, whether they become an inpatient or not down the road. But as you can see, we've got 1, 2, 3, 4, 5, 6 different HL7 feeds right now, either in or out. Now, all of those feeds, I'm going to say, are used more than one time, more than just this piece of our integration, not just our emergency department, but like the ADT feed that's coming out of Meditech. So it's coming out of Meditech, goes into our MedHost. It also goes into about 20 other things that you'll see on the next slide, I think. And so you're able to re-leverage those, reuse them through the engine, make the changes for each individual system that are necessary, whether it's filtering things out or adding data elements or moving data elements around or whatever it might be. That complexity, I guess, and flexibility is built into the engine. But just to give you an idea of how complex it is, what we're working on right now, we've got a test environment, is the ability to have a true pharmacy interface, which is the one real patient safety thing that you do give up if you go to a best-of-breed emergency department. So we've got the concept nailed down. We've got some data flowing. We're testing this, and we hope to turn this live before too much longer. And that, to me, I'm going to feel really good about that. I mean, from a executive, I guess, at our organization who's not concerned about just the IT, but about our patient care and patient safety and things like that, it truly is a legitimate concern that you don't have a good, full, bidirectional pharmacy interface if you have a third-party ED system. So we're going to have that solved pretty soon. I feel really good about that. I think next slide, please, here. So this picture, while it looks very similar to the one we talked about a few moments ago, it's really much different. You see, again, Meditech at the bottom, and then a number of feeds that are defined. Again, whether they go in or out, the directional arrows tell you from Meditech, but those are pure Meditech purchased HL7 messages. And then we route all of those things through our engine, even if we think we're only going to use it once, just for the ability to have it managed through one central point as much as anything else. And then you can see they come and go, and again, color-coded. It's pretty cool. It's nice to have a diagram to go back to. This is fairly recent. I think we've got a few of the things we may be working on since then, but you'll see down in the left-hand bottom corner that I talk about our physician office components. So what we did historically, even in the Magic days, was we would send results back, like laboratory results and imaging results for things we referred to the hospital for providers, whether they were one of our own physician practices or one of the community practices. Well, now we're going a little bit further. I think it's the very next step that's important. Is a true, and someone calls it provider exchange, but we are actually taking an ADT message from those systems when they generate an order for a referral to us and give it to the patient. That electronically sends an ADT message and an order to Meditech. Some has some logic that sort of manages holding that information until the patient presents, because sometimes they don't, and then doing the matching on the patient. Automatically sends the order into the system. When the test is resulted, then of course it automatically sends the results back to the offices. Very cool thing. One of the things I really like is that we've got Allscripts primarily in practices that we own. And in some places, geographic places, we've got a physician office that's using Allscripts, and literally in the doorway next door is our outpatient lab for the hospital. And so we ask the patients, you need a blood test for your physical, walk across the hall, get a blood test, they had to walk across the hall, wait in line to get registered because it was in Meditech, and they don't understand that. We know that it's different and there's billing implications and things like that, but it was a real patient dissatisfier. So now when we ask them to walk across the hall for the lab test, by the time they walk across the hall, the data is going to already be posted in the system. The pre-reg account's already going to exist. The person, even the person who's going to draw, can just validate that information. That registration process finishes. The order's already in the system automatically. Then eliminates all that patient matching problem of getting the results sent back. So we're looking at it as a revenue enhancer for us, for one thing, to try to encourage more referrals and the patient satisfier. And I think that's all on this slide here. Trying to make sure I leave man enough time to actually demo this system here. So I may have just talked about this, the physician offices and what we were doing. In fact, I think I talked about all of this. So we did choose to go with the provider exchange. And again, part of that is it helps us leverage what we already had from an infrastructure as far as the Summit engine and take advantage of some new technology with the coding and the matching of the orders and the registration components. and it's all handled seamlessly, which is, from my perspective, really, really nice. And through true HL7 feeds with Meditech. So the inbound ADT is actually a Meditech feed that you can purchase now and create that registration. But instead of a lot of people use scripting and things like that. So I'm really high on this solution, I think. And we're starting it just with our Allscripts practices. But as soon as we get those live, we're going to do, we talk to the Greenway and eClinical in this community in a number of places. So once you get one going, it's really easy to do the rest of them. So we're looking forward to that being live here very, very soon. Okay, so now that we've got the engine, and if, like I mentioned earlier, some of our future things that you're thinking about are how do you stay with meaningful use, and how do you take advantage of some of the technologies that you have and not always have to buy something new. The public health report, and clearly we route those things through the engine. And I think I mentioned, and I'd like to route it through the engine, and that way we've got one pane of glass, I guess is what the tech guys always like to say to me, to manage things through so that we can get the alerts from one place. We can go view what's going on from one place. Much, much cleaner and easier for us. The communicating with the physician offices, we've talked about what we're doing there. Each state's a little bit different on their syndromic surveillance and those things, but you're able to route those through the engine if you care to. And we did, because I guess timing more than anything, that we were able to have 6.0 in place. And we were already working on CPOE before we started that process. We got enough CPOE and we met all the other thresholds for meaningful use that we did a test last fiscal year. So I felt really good about that. I think in the 6.0 world, there were only maybe 5 or so hospitals that had tested, if I understand Meditech correctly, for fiscal year 11. And that's great. We were able to get back some of the money we put in. Clearly nowhere near what we put in for all the IT, but it's nice to be able to take advantage of that when we can. On the thinking forward component of it in stage 2, even though we don't know exactly what's going to be required, we're pretty sure we know. And one of the solutions is a patient portal of some sort. Clearly far more quality indicators that we need to be thinking about, and how are we going to pull that data out, or where we extract it from. And again, since we've got multiple systems, the integration is really important. That the same thing means the same thing everywhere across the board, and we can get to that data. The rest of the menu sets we're pretty sure will become mandatory, and just waiting for the final regulation on that. And then I mentioned our state has an HIE that we're participating in. So what's the next things for us? And again, from an integration perspective, I think some of these are huge projects. One is a patient portal, and while Meditech does have a product available in 6.06, I believe, we chose to not go with that for a couple of, I hope, the right reasons. But anyhow, we partnered with somebody else. So we're actually starting our work right now on the integration necessary and the setup and thinking through how we're going to phase this from a patient portal. And we want more than just the traditional something that a patient might go to, once every annually. When I have my physical, I'm going to go look at my new lab results or something. We're really thinking about patient engagement. I'm sure you guys all heard about the Supreme Court today and the Affordable Care Act that they've upheld it. Still don't know what that means. I'm not political at all, but the only thing I can say is some sort of health care reform was going to happen over the next 5 years, regardless of who initiates it and what it's called. And primarily it's going to happen because the financial model we have today is just not sustainable. So our interpretation of health care reform is our reimbursement is going to get cut. And we're going to get paid differently. And we know that's going to be based upon quality. It's going to be based upon outcomes, and probably based upon population health management, less so than clicks, patients showing up and us doing something to them. In fact, we'll probably get rewarded for just the opposite in the future. I think the critical thing is aggregating data across all these systems so that we can do the appropriate reporting to show that our quality care or know where our changes have to come in. And so as a component of our portal, we're actually also going to have a clinical viewing component to that too, which will take all of our Meditech data, take the appropriate ED data, take data from physician practices, bring it together, one for the patients to view so that they've got one kind of comprehensive electronic medical record that they can view and manage. But then the second piece of that is for the clinicians in our community. I think with meaningful use, the long-term goal is that we'll have one interoperable healthcare record that's transportable with us wherever we go, and that's great. And we want to participate when that's a reality. Today it's not a reality. Too many different systems, and just very complex environment for that. And so we're trying to at least simplify it for our community. And possibly, we're somewhat rural, and maybe that makes a bit of a difference for us. So we know that we sort of got to drive that. The physician practices in the community cannot afford to make that happen. Yet it's the right thing for our patients, whether they're seen in one of our offices or not. I think having that information available to the clinicians at the point of service is going to be very critical on a go-forward basis. So that's a key piece of what we're doing with our portal solution, starting that now. But then by definition, that's all about integration. It's all about getting the right data in at the right time so that it's presentable to the clinicians when they need it. I'm excited about this. It's going to be a fun project. And probably take us a year to get everything in place the way we want it, but I think we'll be in a really good place. It's something that our community physicians and our hospital-based physicians have been asking for a long time. They don't care that we're not really related to the OB/GYN office or something. They just want to know what's going on with that patient when they come into the emergency department so that they can make better informed decisions. And I think the last thing I talked about, which would be a component or some kind of an adjunct to a portal, is something that's truly going to engage the patients. And we're going to get paid for how healthy they are, and yet there's nothing that's forcing them to be engaged in that process. So we're looking at some kind of solutions that will keep them engaged. I hate to use the word gamification, but I don't know how to describe it, so that you don't look at it once a quarter or every time you visit a physician. It's something that you may go back to daily or multiple times a day to track your wellness, to do different activities, to use some education availability in there, to manage your health, to make sure that you are taking your prescriptions appropriately or whatever. And I think the better we can engage the patients, the better our community outcomes are going to be over the length of time. And we're certain that that's how we'll be reimbursed moving forward. And if nothing else, reducing the cost to take care of these patients, which is probably really where we're going to make our money. It's not going to be on the reimbursement. It's going to be on reducing the overall cost of the community, I think. So same thing. It's all about moving data and having it available to the right people at the right time, and you can't do that without integration. And I think that might be the last slide for me, Tara, and we can go over to Matt for...
Yeah, thank you so much, Ed. That was really, really informational, and I hope everyone on the line found that useful as well. Ed is going to stay on for another 10 minutes or so. I'm going to turn it over to Matt Johnson, so I do encourage folks to stay on. As I mentioned, Matt Johnson is our product manager of our integration platform, and he's going to do a short demonstration of the interoperability platform that Ed just kind of briefly touched upon. So as mentioned, we'll do a Q&A as well, if everyone could just kind of hang tight. Thanks, Matt. I can just see that you've changed over your screen, so I'm going to hand it on over.
Okay. Thank you, Tara. Yes, so what I'm going to try and do today is just a quick review of the layout of our Express Connect product, which is the backbone, all of these integration solutions that Ed has just reviewed with you. So very high level, just kind of a layout of the product, how some of these solutions might be set up with our software and how our tools come together, as well as our dashboard for monitoring, that central monitoring and alerting process. So to get right into it, we have our